All right, welcome to Myasthenia Gravis by Matthew Yonan. So, what is myasthenia gravis? So, breaking down the actual words myasthenia gravis, we can see the origin is Latin. The my part, my, stands for muscle. The asthenia part stands for weakness, and then the gravis stands for grave or serious. So, altogether, it's a serious muscle weakness. So it's essentially an autoimmune disease that affects the skeletal muscle at the neuromuscular junction. So autoimmune disease, meaning that it's caused by the own person's immune system, and it affects skeletal muscle, which is muscle that is connected to tendon, which is connected to bone, as you can see in the picture here. And it's at the neuromuscular junction, which is where the arrow was pointing to, where the neuron of the nerve that is innervating that skeletal muscle essentially synapses with the muscle, the motor end plate. And so this can cause generalized muscle weakness that progresses throughout the day. And the muscles that are generally affected are the eyes, the muscles that move the eyes around, the throat muscles that help with speech and swallowing, bulbar muscles, and the extremities muscles. Um, yeah. So let's look at the physiology of the neuromuscular junction without myasthenia gravis. So then regular physiology. So normally when a signal travels down a nerve and meets at the neuromuscular junction, the neurotransmitter acetylcholine is released through exocytosis across the neuromuscular junction. And you can see that here depicted by these green dots. And so this acetylcholine then binds to nicotinic acetylcholine receptors on the motor end plate, which cause a ligand-gated channel to open, which allows sodium to flow into the motor end plate. There we go, there's the sodium. So once the sodium flows in, it causes a depolarization, and that depolarization can, if enough sodium flows in, can cause an action potential, which propagates down the motor end plate, and can propagate down into the transverse tubules, which you can see here are those um, two passageways where the yellow arrows are going. So after traveling down the transverse tubules, it reaches the sarcoplasmic reticulum, which is essentially like a bag of calcium ions. And so once that signal reaches there, those calcium ions are then released into the sarcomere. So the sarcomere is a unit of actin and myosin overlapping. And so this calcium causes the actin and myosin filaments to slide past each other, which causes a regular muscle contraction. That's the regular contraction. Now let's look at the pathophysiology of myasthenia gravis and how it affects the activity at the neuromuscular junction. So at the neuromuscular junction with myasthenia gravis, their nicotinic receptors or their ACH receptors are blocked by autoantibodies, antibodies that are created by their immune system. So there's no binding, or there's very little binding of acetylcholine to those receptors, which means no opening of the ligand-gated sodium channels. So no sodium, no depolarization, no action potential. And with no action potential, there's no contraction, and the result is muscle weakness. Additionally, these autoantibodies can activate a process called the complement pathway, which can lead to a membrane attack complex being created and these receptors actually being destroyed. So these autoantibodies blocking and destroying ACH receptors originate from the person's own immune system, which is why myasthenia gravis is considered an autoimmune disease. So as far as the clinical presentation goes, there's some classical symptoms and there's patient complaints that come with that. So the classic symptoms include extraocular muscle weakness, which is common on initial presentation, with about 85% of patients saying that they experience this or experiencing this. And that comes with ptosis, which is droopy eyelids, as you can see in the picture on the bottom right. You can see the lady. The one on the left is with no myasthenia gravis, and the one on the right has the droopy eyelids, which is a symptom of myasthenia gravis or gravis, and diplopia, which means double or blurry vision because of the weakness of the extraocular muscles, which are the muscles that are responsible for moving the eye. So the bulbar muscle weakness, which is less common on the initial encounter with around 15%, but is more common with 50% of patients dealing with extraocular positions have this after 2 years. So 50% usually develop it. And this comes with dysphagia, which is difficulty swallowing, dysarthria, which is slurred speech, and dysphonia, which is actually difficulty speaking, because the muscles in the throat are actually, they help with that. And because they're weak, it's hard to speak. And so another body part that is affected by this is limb muscle weakness. And so the upper extremities are affected more than the lower extremities. And so some patient complaints that doctors usually hear about that correspond with myasthenia gravis diagnoses are that they feel exceptionally weaker as the day goes by, and that they have blurry vision, and that they have difficulty chewing and swallowing. So there's also a separate, it's not a symptom, but it's something that can happen with at least once to 15 to 20% of patients with myasthenia gravis, and that's a myasthenic crisis. So a myasthenic crisis occurs when the intercostal muscles, which are the muscles in between the ribs, or the diaphragm, which is the muscle underneath the lung, becomes weak, which leads to respiratory failure. If the ribs are not expanding with the lung because of the stretch of the intercostal muscles, then the lungs are going to have trouble expanding. And so that can lead to respiratory failure. And of course, if the diaphragm cannot contract, allowing air to flow into the lungs, then that would lead to respiratory failure. And so this is a medical emergency that requires intensive care, which will most likely include an endotracheal intubation, which is where they put a tube down your trachea to help you breathe, and mechanical ventilation with that. On a separate note, confirming the diagnosis of myasthenia gravis is one way to do that is through single fiber electromyography, or SFEMG, which is where they record the action potentials of two muscle fibers that are innervated by the same motor neuron. It's a very minuscule test. And so the time between both action potentials will actually increase if someone has myasthenia gravis due to reduced ACH receptor activation because of the autoantibodies blocking that receptor, which decreases sodium flow. And if sodium flows decrease, obviously there's going to be a greater amount of time between both action potentials. All right. So as for treatments, as far as myasthenia gravis goes, so as of today, there is no cure for myasthenia gravis, but there is research that is ongoing, especially here at MSU as well, and with the neurology department. With Dr. Sachdev, I believe. Treating the symptoms of myasthenia gravis include using acetylcholine esterase inhibitors. So what are acetylcholine esterase inhibitors? So acetylcholine esterase is an enzyme that's found on the motor end plate that's responsible for breaking down of excess acetylcholine. So since our myasthenia gravis patient is having trouble having any acetylcholine to activate the ACH receptors, because the receptors are either being broken down by the membrane attack complex or they're being blocked, inhibiting acetylcholine esterase would increase the amount of acetylcholine at the neuromuscular junction or at the synapse, which would then increase the chance for acetylcholine to bind to a receptor because there's more of it, which would cause a depolarization and then a contraction, which is why that works to increase ACH. And one of these agents is called pyridostigmine bromide. And so treating the autoimmune part for patients who fail this acetylcholine esterase inhibitor treatment involves using immunosuppressive drugs, which slow down the creation of autoantibodies. And these include glucocorticosteroids such as prednisone, prednisolone, and methylprednisolone. A third option, which is I'd say the most risky option, would be a thymectomy surgery, which is the removal of the thymus gland. And so the pathophysiology, the reasoning behind why this works is because if there's no thymus, then there's no helper T cells being produced, because that's where they're produced. And if there's no helper T cells, then they can't signal to the B cells to make antibodies. So there's less B cells and there's less autoantibodies that are created. If there's less autoantibodies created, there's less autoantibodies blocking the ACH receptors. And so this is actually found to decrease muscle weakness and help patients in the long run. Thank you for watching.